Students, we're going to look at cellular responses to stress and toxic insults today, and this is part one of two lectures when we're going to discuss cellular responses, cell injury. However, before we start, I would like to introduce myself. My name is Sapargalieva. I'm professor and doctor of medicine. I'm also Vice Director on research work of the Pathology Bureau of the city of Almaty. Today we are starting a lecture course of pathology that includes 15 weeks. It's a very difficult subject and it will require your attention and your commitment, because from my point of view, understanding of pathology would allow you to become good doctors. And I would love to share my 43 years of experience, of pathology experience with you, and I also hope that the knowledge that you'll receive from the Department of Basic Disciplines will help you in your future profession. So I would like us first to discuss the plan of today's lecture. We are going to talk about discipline of pathology, and we'll look at the history of development of this discipline over the ages. We'll talk about categories of causes of cell injury. We'll discuss mechanisms of cell injury. We'll look at reversible cell injury. We'll look at mechanisms of adaptation. We'll stop very briefly on hyperplasia and hypertrophy and atrophy, metaplasia, and irreversible cell injury. But before we start, I would love us to talk about the meaning of the word of the subject we're going to study. So what pathology means? Pathology, as many of other subjects in medical sciences, consists of two words. There is two parts in this word. There is pathos, that means suffering, and logos, that means study. Therefore, pathology as a discipline is devoted to the study of the structural and functional changes in cells, tissues and organs that underlie disease. It is a discipline that bridges clinical practice and basic science, and it involves the investigation of the causes of disease as well as the underlying mechanisms that result in the presenting signs and symptoms of the patient. The investigation of the causes of disease is also known as etiology, while a study of underlying mechanisms is also known as pathogenesis. So I would also recommend you to remember these two very important words, because they will be very helpful in the course of the subject. We cannot study looking into the subject without understanding that history of pathology spans about 4,000 years. On the slide you can see the names of extremely well-known and very prominent specialists who are considered as founders of modern medicine. So Andreas Vesalius, who lived in the 16th century, is a founder of modern human anatomy. William Harvey, who lived at the end of 16th century until mid of the 17th century, was able to describe circulation of blood through the pumping of the heart. And if you think about that, this happens in 1613, so early 17th century. Giovanni Battista Morgani, another prominent scientist who looks at diseases and who comes to the conclusion that diseases had an anatomical and organ basis. Karl von Rokitansky, another prominent pathologist who performed about 30,000 post-mortem examinations in his practice in Vienna. Rudolf Virchow, he's considered the father of modern cellular pathology, and we actually come closer to the 20th century because he actually lived from 1821 to 1902. There are methods that are being used in general and clinical pathology and that have been introduced ages ago. So one of these methods is autopsy. There are several aims of autopsy. It is aimed to identify the cause of death, to clarify causes without clinical diagnosis or in case of unexpected death, to recognize complications of the treatment, to recognize new diseases, to understand the source. It becomes also the source of information for scientific analysis. While one conducts an autopsy, the doctor goes through several stages. There is an external examination of the body, followed by the dissection or internal examination of the body. And based on these earlier stages, the doctor is able to create a pathology diagnosis. And here on the picture you see Andreas Vesalius, an anatomist from the 16th century, who was one of the earliest conductors of autopsy, of this method in general and clinical pathology. Let's go ahead. So there are obviously other methods, and another important method includes biopsy. Histological analysis is considered the gold standard for tissue examination, either for research or diagnostic purposes, for both qualitative and quantitative measures. It is used to assess the inflammation of healing stage and to monitor the presence and distribution of degradation products that dissolves into the surrounding tissue. Different staining is used to identify certain structures, cells, tissues, or even metal components. The most common staining is hematoxylin and eosin, in which the cytoplasm of cells are shown in pink and the nuclear is usually blue. So basically the pieces for biopsy come from several sources. They could be a result of surgery, they could be a result of endoscopic study, including bronchoscopy, gastroscopy, colonoscopy, etc. And there is also large needle biopsy that is used for studying of kidney, liver, lungs, and prostate. So we're continuing to look at modern methods in general in clinical pathology, and it includes electron microscopy, immunofluorescence, immunohistochemistry, morphometry, or also known as flow cytometry, and molecular pathological methods, polymerase chain reaction, probably heard about it. So, first of all, electron microscopy is a technique for obtaining high-resolution images of biological and non-biological specimens. It is used in biomedical research to investigate the detailed structure of tissues, cells, organelles, and macromolecular complexes. Immunofluorescence is an assay which is used tissue and cells and is classically defined as a procedure to detect antigens in cellular contexts using antibodies. Immunohistochemistry is the application of immunostaining. It involves the process of selectively identifying antigens, proteins, in cells of a tissue section by exploiting the principle of antibodies binding specifically to antigens in tissues. Flow cytometry is an emerging technology that combines the statistical power of flow cytometry with spatial and quantitative morphology of digital microscopy. As you probably understood, pathology is a very complex discipline, and it is traditionally divided into general pathology and systemic pathology. General pathology focuses on the fundamental cellular and tissue responses to pathological stimuli. Systemic pathology examines the particular responses of specialized organs. And during our course, we'll be dealing with both general and systemic pathology. There are 4 aspects of disease, and they make the core of pathology. There is etiology, pathogenesis, morphological changes, clinical manifestations. Etiology implies understanding the cause of a disease. And there are 2 major classes of etiologic factors, intrinsic or genetic and acquired, that imply usually infectious, nutritional, chemical or physical factors. Pathogenesis refers to the sequence of events in the response of cells or tissues to the etiologic agent, from the initial stimulus to the ultimate expression of the disease. Morphologic changes refer to the structural alterations in cells or tissues that are either characteristic of the disease or diagnostic of the etiologic process. Clinical manifestations or clinical significance imply the nature of the morphologic changes and their distribution in different organs or tissues. And these clinical manifestations influence normal function and determine the clinical features, including symptoms and signs, course and prognosis of the disease. We used the word disease already a couple of times, so let's try to understand what disease implies. Disease is a disorder of structure or function in a human that produces specific symptoms or that affects a specific location and is not simply a direct result of physical injury. And this semester we'll be looking and discussing different subjects in general pathology, and that implies that we will be looking at mechanisms of disease development and morphological manifestations of diseases. We will have to compare all these pathological conditions with healthy tissue. So health implies the state of complete emotional and physical well-being. One of the issues and terminological aspects that you also should know is homeostasis. Homeostasis is the maintenance of a constant internal environment. Cells are active participants in their environment, constantly adjusting their structure and function to accommodate changing demands and extracellular stresses. Cells tend to maintain their intracellular milieu within a fairly narrow range of physiological parameters. That is, they maintain normal homeostasis. Homeostasis is all about balance. It comes from the Greek words that mean the same or steady, and it refers to any process that living things use to actively maintain fairly stable conditions necessary for survival. As cells encounter physiologic stresses or pathologic stimuli, then they can undergo adaptation, achieving a new steady state and preserving viability and function. On the next slide, we'll look at principal adaptive responses of cell. And there are 4 such kind of responses: hypertrophy, hyperplasia, atrophy, and metaplasia. If the adaptive capability is exceeded or if the external stress is inherently harmful, cell injury develops. Within certain limits, injury is reversible and cells return to a stable baseline. However, severe or persistent stress results in irreversible injury and death of the affected cells. We will briefly look at all these responses on the following slides. Physiologic adaptations and pathologic adaptations represent two types of cellular adaptations to stress. Physiologic adaptations usually represent responses of cells to normal stimulation by hormones or endogenous chemical mediators. Pathologic adaptations are responses to stress that allow cells to modulate their structure and function and thus escape injury. So here we'll consider hypertrophy. Hypertrophy usually implies an increase in the size of cells, resulting in an increase in the size of organ. And on the left you can see a schematic representation of this process, while on the right you see an athlete with whose muscles are undergoing this process of hypertrophy. There are examples of pathological cellular hypertrophy, and they could be seen, for example, in the cardiac enlargement that occurs with hypertension or aortic valve disease. The mechanisms driving cardiac hypertrophy involve at least two types of signals: mechanical triggers such as stretch and trophic triggers such as activation of alpha adrenergic receptors. Physiologic hypertrophy of the uterus during pregnancy is presented on this slide. The gross appearance of a normal uterus on the right, while you can see on the left a gravid uterus removed from the postpartum bleeding. So you can see also, please pay attention to the stars. The small spindle-shaped uterine smooth muscle cells from a normal uterus are represented on this middle picture, and you can see the yellow star there. And please try to compare it with large plum cells in gravid uterus, and this is signified with this green star. Hyperplasia is another adaptive response in cells capable of replication. And it can be divided into physiologic hyperplasia, including hormonal hyperplasia and compensatory hyperplasia, and there is also the pathologic hyperplasia. So hormonal hyperplasia exemplified by the proliferation of the glandular epithelium of the female breast at puberty and during pregnancy. Compensatory hyperplasia is hyperplasia that occurs when a portion of the tissue is removed or diseased. Pathologic hyperplasia is caused by excessive hormonal or growth factor stimulation. If the balance between estrogen and progesterone is disturbed, endometrial hyperplasia ensues, a common cause of abnormal menstrual bleeding. So on this slide you see two photos with a normal endometrium on your left and hyperplasia on your right. On your left, you see the yellow star that demonstrates proliferative phase endometrium. There is also a green star on the same picture that shows myometrium composed of smooth muscle bundles below the endometrial layer, which lines the central endometrial cavity of the uterus. Closely packed glands, such that gland to stroma ratio is 3:1, but stroma is still present between glandular basement membranes. Variation in gland size with cystic dilatation or regular luminal contours, budding, angulation, invagination, outpouching, papillary projections. It is associated with stromal breakdown, increased volume of endometrial tissue on biopsy, and keratin is typical but not required for diagnosis. There are also other cytological features. They're reminiscent of normal proliferative endometrium with pseudostratified, mitotically active, elongated columnar cells. This can show mild cellular enlargement but retain smooth nuclear contours without distinct nucleoli. Here you can look at benign prostatic hyperplasia, also known as prostate enlargement, and it is a non-cancerous increase in size of the prostate gland. Glands, signified with a green star, become hyperplastic. Medium glands with two benign cell layers, secretory and basal, showing some architectural complexity, including papillary enfoldings, and this is shown by the blue arrow. Another cellular reaction is atrophy. Atrophy implies shrinkage in the size of the cell by the loss of cell substance, and it is well shown by these two pictures. On the left you can see a normal brain of a young adult. On the right there is atrophy of the brain in an 82-year-old male with atherosclerotic disease. Atrophy of the brain is due to reduced blood supply. Note that loss of brain substance narrows the gyri and widens the sulci. So this is shown by the red star. Cachexia is a weakness and wasting of the body due to severe chronic illness. And this illness, it can be represented by lung cancer and gastrointestinal tumors. These are the two tumors most likely to cause cancer cachexia. The occurrence of cachexia in patients with advanced lung cancer indicates that the patients are already at an extreme severe nutritional risk. Approximately 22% of lung cancer patients' deaths are related to cachexia. Metaplasia is another reaction. One adult cell type, epithelial or mesenchymal, is replaced by another adult cell type. So on this picture we see a scheme on the top, right, and the photo, the microslide at the bottom. So on the top we can observe metaplasia of normal columnar to squamous epithelium in a bronchus, so shown schematically and histologically. The green stars demonstrate columnar epithelium, while yellow stars show squamous epithelium. The metaplastic squamous epithelium has survival advantages. Important protective mechanisms are lost, such as mucus secretion and ciliary clearance of particulate matter. Metaplastic transformation may predispose to malignant transformation of epithelium. In a common form of lung cancer, squamous metaplasia of the respiratory epithelium often coexists with cancers composed of malignant squamous cells. Cigarette smoking initially causes squamous metaplasia, and cancers arise later in some of these altered foci. Metaplasia also could be seen in lower esophagus. So we see two pictures, and in normal condition, The esophagus is lined with stratified squamous epithelium, and you can look at the yellow star on the left picture. We still see squamous epithelium of the lower esophagus that undergoes metaplastic transformation to gastric columnar epithelium. So squamous epithelium, again shown by this yellow star on the right picture, undergoes a transformation to gastric columnar epithelium, shown by the green star. So considering we discussed several cellular responses, these are questions for self-check regarding the adaptation. On the left, you can see normal cells. On the right, you observe the process of adaptation. And on the next slide, we will find the answers to the questions. But I would also recommend you to try to think what type of adaptation these cells are undergoing. So let's have a look where this is the answer to the previous slide. So we have normal cells, then we have cells experiencing atrophy, cells experiencing hypertrophy, increased cell and organ size, hyperplasia, increased cell numbers, and metaplasia, change in phenotype of differentiated cells. This is probably a familiar picture from Robbins' Pathology, and this is our textbook for this course. However, right now you should be able to understand the meaning of adaptation. On the next slides, we will learn about other components of these schemes. Cell injury, reversible cell injury, and subcellular alterations, necrosis, and apoptosis. The relationship between normal, adapted, reversibly injured, and dead myocardial cells are presented on this slide. The cellular adaptation depicted here is hypertrophy, signified by yellow stars, and the type of cell death is ischemic necrosis, and you can look at the green star here. In reversibly injured myocardium, generally effects are only functional without any readily apparent growth or even microscopic changes, and there are free transverse sections. In the example of myocardial hypertrophy with the yellow star, the left ventricular wall is more than 2 centimeters in thickness. Normal is 1 to 1.5 centimeter. In the specimen showing necrosis, the transmural light area in the posterolateral left ventricle represents an acute myocardial infarction. So these are the causes of cell injury: hypoxia, oxygen deficiency, chemical agents, infections agents, immunologic reactions, genetic defects, nutritional imbalances, physical agents, and aging. Causes of hypoxia can vary from inadequate oxygenation of the blood in pneumonia, reduction in the oxygen carrying capacity of the blood in anemia, or carbon monoxide poisoning. Chemical agents imply air pollutants, insecticides, carbon monoxide, asbestos, and social stimuli such as ethanol. Infections agents mean viruses, rickettsia, bacteria, fungi, protozoans, as well as metallon tapeworms. Immune reactions can result in cell and tissue injury, including allergic reactions. Genetic defects may cause cell injury because of deficiency of functional proteins such as enzymes in inborn errors of metabolism. Ironically, excesses of nutrition are important causes of morbidity and mortality. For example, obesity markedly increases the risk for type 2 diabetes mellitus. There are also physical agents, including trauma, extremes of temperatures, radiation, electric shock, and sudden changes in atmospheric pressure. Aging leads to alterations in replicative and repair abilities of individual cells and tissues. This picture is from Robbins Pathology. Includes 3 levels. On the top, you can see the normal condition of the cell. At the middle level, you see the cell responses to reversible injury. At the lower level, you see the cell responses to irreversible injury. Reversible injury is characterized by generalized swelling of the cell and its organelles, blebbing of the plasma membranes, detachment of ribosomes from the endoplasmic reticulum, clumping of nuclear chromatin. Transition to irreversible injury is characterized by increasing swelling of the cell, swelling and disruption of lysosomes, presence of large amorphous densities in swollen mitochondria, disruption of cellular membranes, profound nuclear changes. The nuclear changes include nuclear condensation, pycnosis, followed by fragmentation, karyorrhexis, and dissolution of the nucleus, karyolysis. Laminated structures, myelin figures, derived from damaged membranes of organelles, and the plasma membrane first appear during the reversible stage and become more pronounced in irreversibly damaged cells. On this picture, on this slide, you see 2 pictures. There are morphological changes in reversible cell injury. On the left is a normal kidney tubulus with viable epithelial cells, signified by yellow star. On the right, there are early reversible ischemic injuries showing with surface blebs. Pay attention, there is a blue star there. Increased azoophilia of cytoplasm. Here we go, there is a black star, and swelling of occasional cells. This is another example, like fatty change. So on the left you see the normal liver. On the right there is fatty change, fatty liver, that is manifested by the appearance of lipid vacuoles with blue star in the cytoplasm. It is principally encountered in cells participating in fat metabolism, including hepatocytes and myocardial cells, and is also considered reversible. Within certain limits, injury is reversible and cells return to stable baseline. However, severe or persistent stress results in irreversible injury and death of affected cells. Cell death is one of the most crucial events in the evolution of disease in any tissue or organ. It results from diverse causes including ischemia, lack of blood flow, infections, toxins, and immune reactions. Cell death is also a normal and essential process in embryogenesis, the development of organs and the maintenance of homeostasis. This is another picture from Robbins Pathology, and you can observe 2 types of cell death, necrosis and apoptosis. Necrosis is the premature death of cells and living tissue. It is considered an unprogrammed cell death process at this time, caused by factors external to the cell or tissue such as infection, toxins, or trauma, membrane disruption, respiratory poisons, and hypoxia, which cause ATP depletion, metabolic collapse, cell swelling, and rupture leading to inflammation. Inflammation, decreasing blood flow at affected site, tissue death, including gangrene. Apoptosis is a programmed cell death, is a form of cell death that is generally triggered by normal healthy processes in the body. Membrane blebbing, shrinkage of cell, nuclear collapse, including nuclear fragmentation, chromatin condensation, chromosomal DNA fragmentation, as well as apoptotic body formation. Then, engulfed by white blood cells, usually there are no noticeable symptoms related to this process. Necrosis refers to a spectrum of morphologic changes as they progressively injure the cell and follow its death. Please look at this picture. Here you can see three types of nuclear death: karyolysis, karyopyknosis, and karyorhexis. You should know that absence of nuclear implies the death of the cell. Therefore, this is the most crucial characteristic of the cell death. On the further slides, we will briefly examine these three types of the nuclear death. Karyolysis is the complete dissolution of the chromatin of a dying cell in brain due to the enzymatic degradation by endonucleases. On the slide you can see that the contour of nuclear is lacking due to the process of lysis. Karyopyknosis is the irreversible condensation of chromatin in the nucleus of hepatocytes undergoing necrosis. The nuclear in the cell becomes small and changes the coloration. With hematoxylin and eosin staining, the normal nuclear has dark blue color, while during the process of karyopyknosis, the coloration of nuclear changes to black. Karyorhexis is the destructive fragmentation of the nucleus of dying cells in myocardium. You can see multiple pieces of chromatin between the cardiomyocytes lacking the nuclear. There are different classifications of necrosis. Here you can see the classification that has been developed in the 19th century. Originally, the clinicians were using this classification along with pathologists. However, despite its age, this classification is still relevant even today. Therefore, let's have a look at the features of each type of necrosis. Coagulative necrosis is a form of tissue necrosis in which the component cells are dead, but the basic tissue's architecture is preserved for at least several days. Liquefactive necrosis is a transformation of the tissue into a liquid, viscous mass. Gangrenous necrosis is usually applied to a limb, generally the lower leg, that has lost its blood supply. Caseous necrosis is characterized by acellular pink areas of necrosis surrounded by a granulomatous inflammatory process. Fat necrosis refers to focal areas of fat destruction resulting from release of activated pancreatic lipases into the substance of the pancreas. Fibrinoid necrosis usually seen in immune reactions involving blood vessels. Let's consider coagulative necrosis. Two large infections, areas of coagulative necrosis, are seen, and you can see the blue stars. Two large infections are seen in the section spleen. Since the etiology of coagulative necrosis is usually vascular with loss of blood supply, the infection occurs in a vascular distribution. Those infections are often wedge-shaped with a base on the organ capsule. Coagulative necrosis is seen in infection in a tissue, with the exception of brain. The etiology is loss of blood. You can see the gross section with the tissue in areas of coagulative necrosis that is firm, with very distinctive border between normal tissue and foci of coagulative necrosis. Pay attention to blue stars. On the right, you can see the microimage. Here is the coronary artery with atherosclerosis and recent thrombus filling the lumen. And this process is signified by the yellow star. This is another photo of coagulative necrosis. However, here we're looking at the microimage. The contrast between normal adrenal cortex and the small pale infarction can be seen very, very well, and pay attention to the blue star. The area just under the capsule is spared because of blood supply from capsular arterial branches. This is an odd play for infarction, but it illustrates the shape and appearance of an ischemic infarction very, very well. This is an example of liquefactive necrosis. That's another type of necrosis. This is intermediate infarction of the frontal lobe that shows liquefactive necrosis with formation of cystic spaces, signified by this blue star, as we can observe the resolution process. The cerebral infarction demonstrates the presence of many macrophages. Look at the right slide and look at the black star, which are cleaning up in the lipid debris from the liquefactive necrosis. As we mentioned earlier, there is also gangrenous necrosis or gangrene. That is a type of necrosis, and there are two types of gangrene: dry gangrene and wet gangrene. Dry gangrene happens due to insufficient blood flow to the tissue, typically from atherosclerosis. So the black gangrene is seen on the left. The wet gangrene on the right involves bacterial infection, usually with skin flora, and the difference, the pathological, morphological differences shown by these two stars. This is a clinical case of a 73-year-old man with a long history of diabetes mellitus. He had a history of having ulcers on his left foot that healed slowly. However, over several weeks, his entire left foot began to show progressive black discoloration, eventually extending to involve much of the left lower extremity. Popliteal and dorsalis pedis pulses could not be palpated, and above the knee amputation was performed as a result. The left femoral artery has marked intimal atherosclerosis and focal calcification. The lumen was occluded by recent and remote thrombus. So this result of amputation, you see it on the slide. It demonstrates gangrenous necrosis from severe peripheral atherosclerosis in a patient with poorly controlled diabetes mellitus. The next type of necrosis is caseous necrosis. On the left side, you can see macro image. The tissue maintains a cheese-like appearance, and pay attention to the blue star. On the right, there is a micro image. This is granuloma, that is diagnostic lesion of both caseous and tuberculous condition. The arrow points to four components that are extremely important: a central caseous necrotic core, concentrically arranged epithelioid-like cells, peripheral zone of lymphocytes, and presence of Langerhans giant cells. Another type of necrosis is fat necrosis in, for example, acute pancreatitis. Fat necrosis appears as yellowish white. On the left, look at the black stars. On the right, there are necrosed fat cells that have cloudy appearance surrounded by inflammatory reactions. So pay attention to these two red stars showing this cloudy fat, necrosed fat cells. Fibrinoid necrosis is another type of necrosis that is characterized by deposition of fibrin-like material, which has the staining properties of fibrin. Fibrinoid necrosis in an artery in a patient with polyarthritis nodosa is presented on this slide. The wall of the artery shows a circumferential bright pink area of necrosis with protein deposition and inflammation, dark nuclei of neutrophils. So we listened to the first half of this lecture, and at the end I would like to offer you a clinical case. I would like to you to think that this is your patient that was, that you consulted, and right now you have to make a conclusion regarding the cause of her death, and you have to write this final diagnosis. So, this is a case of a person who actually lived for real, and Cleopatra VII, she ruled ancient Egypt as a co-regent for almost 3 decades. She became the last in a dynasty of Macedonian rulers founded by Ptolemy, who served as general under Alexander the Great during his conquest of Egypt. She was very well educated and clever. She spoke several languages and served as a dominant ruler in all 3 of her co-regencies. And she's well known for her romantic liaisons and military alliances with Roman leaders, including Julius Caesar and Mark Antony, as well as her supposed exotic beauty and powers of seduction. So basically, this all had earned her an enduring place in history and popular myth. So let's think about her as a patient. On August 12, 30 BC, Cleopatra closed herself in her chamber. Even today, it is not well known the reason or the cause of her death. However, Plutarch and other writers had several theories that she used a poisonous snake known as the asp. So this is what Plutarch writes. Cleopatra sent to Caesar a letter which she had written and sealed, and putting everybody out of the monument but her 2 women, she shut the doors. The Caesar's messengers came at full speed, and on opening the doors they saw her stone dead, lying upon a bed of gold set out in all her royal ornaments. Eros, one of her women, lay dying at her feet, and Charmion, just ready to fall, scarce able to hold up her head, was adjusting her mistress's diadem. And when one that came in said angrily, "Was this well done of your lady, Charmion?" "Extremely well," she answered, and as became the descendant of so many kings, and as she said this, she fell down dead by the bedside. So this is what the chronic says. And it is supposed that Cleopatra died from a snake bite, and she's often depicted with this asp clinging to her image. In the Aeneid, Virgil speaks of the queen not turning her head to see twin snakes of death behind. Horace and Propertius also speak of 2 snakes, not one, although the other primary source, Velesius, does mention a single asp. So there are a lot of different snakes associated with Cleopatra, but usually the asp. The manner of Cleopatra's death was exotic one, befitting a queen of Egypt. If by the bite of the cobra, it would have been even more symbolic, as the snake was emblematic of the image of the queen that was worn on her pharaonic headdress. It would have been ironic as well, as cobra also signified. It was supposed to protect the queen. It would have been meant for her death. So I would like you to offer a couple of questions. We just read the chronic and description by Plutarch of what had happened, with Cleopatra. But I would like you to think about her as a patient. And there are several questions that for your consideration. So is it possible to recognize this tissue damage in a macro image without a hint from the text? Try to highlight all changes in an organ that could be considered as markers for the diagnosis. Highlight all changes in an organ or tissue that could be considered additional for the diagnosis. What else would you, for example, need for the diagnosis? Think what has caused morphological changes that you observe, for example, in the microimage. What complications are associated with the pathological process in question, and try at the end to formulate a diagnosis and make sure that the etiology, pathogenesis and nosology are reflected in the diagnosis. This is it for today. Thank you so much for listening.